Good morning out there. It may not be morning for you, but it's morning for me right now. This is a bit odd having to record in advance. You don't get to see my beautiful yet tired and slightly haggard face, and I don't get to see yours either. Looking forward to being able to do more things in person. I am actually thrilled to be able to do this little talk for you, and I hope that you find it helpful. And I've been asked to talk today about deprescribing. So my name's Martha Carmichael. I'm a doctor. I'm a geriatrician and the medical director of the Provincial Geriatric program. So I do a lot of thinking and talking about deprescribing. So my objectives today are pretty simple. I'll introduce myself a little bit, talk a little bit about our aging population. I'll talk a little bit about medications in older adults, and then about deprescribing, but more specifically about appropriate prescribing of medications. And then I'll give you a couple of tools and resources that you can go to if you want a little bit more information. So I am an internist geriatrician. So I did my internal medicine training at Dalhousie, and then I went on to Toronto to do training in geriatric medicine. And I started my career at Sinai Health System in Toronto. And now I'm the medical director of the Provincial Geriatric program of PEI, and I've been here for about 4 years. I have particular interest in acute care, in quality improvement, in program development, and we're doing a lot of that lately, and also in health systems and health policy. This is just my little joke showing how I moved from downtown Toronto to downtown Summerside about 4 years ago, but we have settled in very nicely here, and we're very happy here. So it's not going to be a surprise to anyone that our population is aging. Older Canadians are actually now the fastest growing segment of our population, and the absolute number of older Canadians is projected to double over the next 20 years. So certainly that presents some challenges, but I also believe that it presents great opportunity for us. And now is the time for us to really transform our communities, but also our healthcare system in order to better care for older adults. In terms of specific numbers, in Canada at the moment, about 15% of people are over age 65. That's projected to increase to 30% over the next 20 years. And about 2.5% of the Canadian population is over age 85, and that's projected to increase to 10% over the next 20 years. In PEI, I actually should update these numbers because these are a little bit older and it's actually higher now. But at this time, there were about 19% of us over age 65, which was projected to increase to 28% in the next 20 years. And 2% of us are over age 85, projected to increase to 4%. So the bottom line is basically that more than 1 in 4 Islanders will be 65 years old or better in 20 years. So, you know, we talk about our aging population. Is that a bad thing? We certainly hear mixed things, right? We hear terms like this: gray tsunami, silver tsunami, the age wave, the rising tide, and the worst one, I think, the gray horde. So certainly all of these words and phrases would probably sway us towards thinking it's a bad thing. But I would completely disagree. So I think it's amazing. And I think it's amazing what we've been able to do with our life expectancy over the last century. So 100 years ago, our life expectancy would have been about age 50, and now it's 80, and it's actually over 80 for both males and females now in Canada. And the more important part, I think, is that most of us are actually enjoying good health and good quality of life in those extra years. So I think that's absolutely a good thing. In fact, if you look at life expectancy of Canadian older folk, if you are lucky enough to achieve age 65, you can be expected to have about 19 years of life expectancy left on average. So your life expectancy is about 84 years old. At age 75, you can be expected to have maybe 12 years of life expectancy left, again, on average, so about 87 years old. At age 85, still, you can expect to have 7 years of life expectancy left on average, so about 92 years old. And then at age 90, you can still be expected to have about 5 years of life expectancy left, and that on average, of course, and that's about 95 years old. So at every age, it is higher for women than men. But what it means and what this shows you is that older adults are actually survivors. So the older you are, the older you may actually get. And this is one of my mentors, Dr. Samir Sinha, who works in Toronto. And he has always said that aging is a triumph, not a tragedy. And I really try to convey that message in all the work that I do as well. So the headlines, though, they say things like this: a health system headed for crisis as the number of seniors double, code gridlock, why we need a national senior strategy, and we do. When a stagnant health system meets an aging population, disaster awaits. So all of those things highlight the fact that we have definite challenges facing us as our population ages. And all of those concerns are largely centered around a fear about increasing costs. So I told you initially that about 15% of Canadians are over age 65, but that small percentage of population actually accounts for almost half of our health and social care spending. In hospitals specifically, older adults make up about a third of emergency department visits, about 40% of hospital admissions, about 60% of hospital inpatient days, and then about 75% of inpatient rehabilitation days. So all that means really is that older adults are more likely to show up in the emergency department. When they show up in the emergency department, they're more likely to need to be admitted to hospital. When they're admitted to hospital, they are more likely to have to stay longer in hospital than younger people. And then before they're able to go home, they're often needing a stay in a rehabilitation facility or unit in order to get some of their lost function back before they can go home. So the cognitive shift, I often have to remind people in healthcare about this. It's better when I'm talking to the general population like you folks, but in healthcare, we sometimes forget this. So the important thing for us to remember is that only about 5% of seniors are consistently high users of the healthcare system, and that most complex 10% of seniors or older adults accounts for about 60% of our collective spending. And then the least complex half, so that half of older seniors that is the least complex, only account for about 6% of our collective spending. So as I said earlier, most older adults are enjoying relatively good health and quality of life in their older years. And we do forget this in hospital and in the acute care system. Older adults are a very heterogeneous group. And I think we also forget sometimes in healthcare and in hospital that older adults have contributed to our collective growth and our country's prosperity more than any other generation. And older adults are vital and active members of our society. So older adults are our grandparents, our parents, uncles, aunts, neighbors, friends, coworkers. And again, that most older adults are living longer and living well. And 90% of older adults are living independently in the community where they want to be. Things do change with age, however. So as we get older, the chance of having a chronic condition increases. So about 75 to 80% of older adults report having at least one chronic condition. As we get older too, we then end up taking more medications to manage those chronic conditions. And also the benefits and risks of various medications change as we age and as our body changes. I'm going to talk about deprescribing and appropriate prescribing, but I certainly would not argue that medications are bad. I don't think any of us would. So medications are often very necessary for health. They're often very necessary to improve quality of life and improve symptoms for older adults. Medications are very important in terms of managing chronic conditions like diabetes or high blood pressure or chronic pain even. And managing those chronic conditions can decrease our risk of further problems in the future like stroke or heart attack. And medications often are needed to prolong our life expectancy. But as we get older, things do change, as I said. The brain is much more sensitive to drug effects as we get older. Our liver and our kidneys, which process medications, they don't do that as efficiently, and that kind of changes a bit. And the result of that is that medications can last longer in our body. We have less muscle as we age and more fat, so medications kind of hang around longer than they would have in our younger years. And medications can also be more concentrated. We have less total body water as we age, so the dosing of medications is a bit different as we age. Are seniors on too many medications? So I've said that the number of chronic conditions increases with age, and the number of medications prescribed to treat those chronic conditions increases with age. But are seniors on too many medications? So if you look at the numbers, if you look at the data, this is from the Canadian Deprescribing Network. About 2 out of 3 Canadians over the age of 65 take at least 5 different prescription medications every day. And 1 out of 4 Canadians over the age of 65 take at least 10 different prescription medications a day. And so what that means, while some of those or all of those might be very appropriate, is that with increasing number of medications, there actually are increased risks of medication harms, unsurprisingly. Polypharmacy is the term we use to describe more than 5 medications, and the definition is different anywhere you look, but generally accepted that more than 5 medications we call polypharmacy. And the reason we have a term for it and we call it polypharmacy is just that taking that many medications increases our risk of suffering medication harms or experiencing medication harms. And medication harms include things like drug interactions, so interactions between or among the different drugs we're taking, falls and fractures, so falls and or broken bones as a result of those falls, memory problems, cognitive impairment, and also hospitalizations and unfortunately death. The risk of drug-drug interactions actually increases as the number of medications we take increase, again, not surprisingly. So when medications interact with each other, they can have unpredictable effects, and those are called drug-drug interactions. And again, the more medications we take, the higher risk of drug-drug interactions. As you can see here on the right, the graph, if you take only 2 medications, you are at relatively low risk of drug-drug interactions. And if you take 8 to 10 medications, you have an 8-fold greater risk of drug-drug interactions. Who is most at risk? There are 3 groups who seem to be most at risk of suffering or experiencing medication harms. That is people with multiple chronic conditions, which makes sense because those are the people who are going to be prescribed probably many medications. And unfortunately, these people are at risk for drug-drug interactions, so interactions between the different drugs or among the different drugs they're taking, but also drug-disease interactions. So one medication you're taking for one of your chronic conditions might actually make one of your other chronic conditions worse. The second group is just people over age 65. So I said a lot changes in the body in terms of how we metabolize drugs and the effect drugs have on our bodies and our brains as we age. But also people over age 65 have traditionally been excluded from many drug trials. So the evidence in this patient population is much more limited. And the last group is women. So again, women are less studied than men at any age. And women in much of the research have been found to be more likely prescribed risky medications, so things like sedative hypnotics, so sleeping pills and things like that. And women are also probably more susceptible to the harmful effects of medications for whatever reason. So those are the 3 groups of people who are most at risk. If you look at the numbers, and this is slightly old data now, this is 2016, but 1 in 143 seniors, so about 0.7% of seniors in Canada were hospitalized due to an adverse drug reaction or harmful effects of their medication. So what that added up to was about 41,000 seniors hospitalized in a given year, directly linked to problems with their medications. And then the question is about inappropriate medication. So Appropriate medications can expose patients and people to risks, but inappropriate medications, you may be exposing people to risk without any benefit. So inappropriate medications are medications that expose patients to a greater risk when compared with available alternatives. So available alternatives might be a different drug or a different medication or non-drug therapies, so non-pharmacologic therapies. If you look at the number or the percentages of Canadian seniors who take at least one potentially inappropriate medication, in those over 65 years old, it's about 31% for men and about 42% for women. And then if you look at those over 85 years old, it's about 39% for men and 47% for women. So that's certainly important on an individual level, because we certainly don't want any individuals to be exposed to more risk than benefit as a result of a medication. But it's also really important for our system. And this is looking at it just in terms of dollars and cents. So not even things like hospital capacity and that sort of thing, but just dollars and cents. So if you look on the left, unfortunately, about $419 million a year is spent in Canada on potentially harmful prescription medications. These are medications that are prescribed to people and to patients that may be potentially harmful. That is the amount of money we spend on those actual medications. And then if you look at the right side, $1.4 billion per year, unfortunately, is spent in Canada on healthcare costs related to potentially harmful medications, including faints, falls, fractures or broken bones, emergency department visits, and hospitalizations related to harmful medications. So that is obviously significant. So what do we do about all of that? And the key really is deprescribing. And so that's what I'm going to talk to you a little bit about now. So deprescribing is the planned and supervised process of reducing or stopping medications that may no longer be of benefit or may be causing harm. And I think we were not necessarily great at this in the past, but doctors and nurses and nurse practitioners and pharmacists are getting much better at this as time goes on. So patients themselves can be very helpful in this process. This is a list of questions that the Canadian Deprescribing Network suggests that patients ask their healthcare providers. And again, that may be your physician, it might be your nurse practitioner, it might be a nurse or a pharmacist, but the questions are here. So first of all, why am I taking this medication? And it's amazing. Sometimes both patient and provider have forgotten why they were taking the medication in the first place. Sometimes the provider remembers why they were prescribed it, but was not, did not know that the patient was still taking that medication. So it's a very important question to ask. The second question is, what are the potential benefits and harms of this medication, which is very important. And as I said, things change as you age. So the potential benefits and risks change over time as well. So it's really important to readdress over time. The third question is, can it affect my memory or cause me to fall? Because those are very serious and significant concerns for older adults. And the fourth is, okay, can I stop or reduce the dose of this medication? And then the last question is, who do I follow up with and when? And I have put in red at the bottom that this is, these questions are to be discussed with healthcare providers. There are a lot of medications that you should not stop cold turkey. They really need to be tapered down, and you really should do that in collaboration with a healthcare provider. But these are good questions to ask in terms of a jumping off point with your healthcare provider. So I try to give these questions to patients and family members so that they can have this conversation with their providers. Medication management is a huge part of what we do. And I said I'm a geriatrician, so I'm a specialist for seniors. So I spend almost all of my clinical time with seniors, so a huge part of what we do. And we know that we should frequently review medications, the indications for those medications, as well as the risks and benefits. I would argue at least yearly. We do a pretty thorough medication review on every patient that we see, but it would be great if patients could have that type of review yearly. And pharmacists have also become much more helpful with this over the last little while. So you can get medication reviews like this at many pharmacies across the island. Some conditions actually require a lot of medication. So even one condition might require 5 medications. So it's really, the question is really about appropriate prescribing. So what am I taking that I don't need? So what might we be able to deprescribe? But also the second question is, what am I not taking that I should be taking? And so there are some things that we may actually want to add in to the medication regimen that might have been missed. So definitely deprescribing is important, but also looking at appropriate prescribing and making sure we are on the medications that we should be on for our given age and stage. I will tell you very quickly before I finish a little story about a woman I will call Kate. She was a 70-year-old woman who was referred to me from the emergency department, and she had been having difficulty with pain, falls, and confusion. So was seen in the emergency department, and the emergency room or the emergency department physician really felt that her biggest problem might be polypharmacy. So he sent me a note saying, would you mind seeing this person in your clinic? I think she needs some deprescribing, but I'm not sure where to start. And Kate's story was actually fairly typical, but not a very happy one. So Kate had been a very active woman. She was a hairstylist, she was a dancer, she was a business owner. And she started to have a couple of health problems, chronic health conditions. She started to accumulate chronic conditions. She was diagnosed with diabetes and had some difficulties with her blood sugars. She was then diagnosed with heart disease. I think she had a minor heart attack. And she had bladder problems, so difficulty with her bladder and also chronic bladder infections. And all of these things kind of impacted her function. So she was no longer able to work. She lost her business and she was no longer able to dance. She ended up having a lot of chronic pain. She became depressed. She felt dependent on her daughter for assistance. And all of that led to her being fairly hopeless. These were her medications when I met her. And when pharmacists take a look at this list, they cringe. But she was on 16 prescription medications and taking over 39 pills per day. So what I did was I followed her very closely. I linked very closely with her family doctor and with her pharmacy, and we initiated a bunch of changes. So I won't go through the details here, but I stopped a bunch of medications fairly quickly, the ones that were able to be stopped fairly quickly. I tapered down several others. And we worked on very, very, very slow tapers of a couple of the ones that you have to be a bit careful with. And then we looked at other appropriate therapy that she was not on. So one thing was vaginal estrogen to help with her bladder infections. And I also referred her to our infectious disease specialist about that to see if we could help her. And Kate actually did very well. So several months later, we had cut down her medication list basically in half. So she was still on 7 prescription medications, but we continued to taper 2 of them. And she was actually feeling great. She had become a bit more functional. Her pain was better. Her cognition was better. She didn't feel as cloudy. And her mood was therefore better as well. Now, things didn't go entirely smoothly with her. So sometimes it's like the slide on the left where you deprescribe, everything gets better and you can kind of move on. But with Kate, she had some ups and downs. So with her, the problem was every time she got admitted to the hospital, a couple of new medications would be added on. So we did have some ups and downs with her, and I actually continue to follow her to this day. So a lot of people ask me, it's fine to have a review by a geriatrician of medications, appropriate medications, but what can we do as patients and as citizens? And so this is what I would suggest. I'd suggest that you should educate yourself about what medications you're taking and why. I would suggest that you should engage in a discussion with your healthcare provider about deprescribing options and also alternate therapies. Like, is there anything else we could do for this that wouldn't require medication? And you can use those 5 questions I gave you earlier in order to kind of help guide that conversation. And I would also encourage you to spread the word about medication harms and also deprescribing to friends and family, to advocacy groups, government representatives, anyone you're having conversation with, in order to minimize the harms of our older adults across the island. There is a tool available online called MedStopper that can help you assess whether or not you're taking any risky medications, and the web address is there. So I encourage you to ask questions, to stay informed, to be proactive, and to participate in making smart choices with your healthcare provider. These are some resources that are very helpful, and there are more even on the Deprescribing Network website, and the website is there. So they have a lot of information about the risks and benefits of various medications, and also the benefits of deprescribing. So I suggest you take a look at that website. And that is it. I usually have time for questions, and I wish that I could answer some questions for you, but if you do have questions, feel free to email me. And I hope this was helpful for you, and have a good day.